Welcome to our third lecture in our 5-part series on breast. This lecture is going to cover breast ultrasound. Now, normal breast tissue under ultrasound shows those layers really well. So that's why we talked about all those layers first. We want to be able to know what the layers are, so now we can apply what they look like by ultrasound. So every time that you are practicing in lab looking at breast structures, if you are watching videos during our lab time and they're showing breast images, kind of take a look through. Can you identify where the skin is, where the premammary layer is, where's the glandular layer? If you can identify all those, that's going to be an awesome assurance that you know what you're doing when you're looking at the breast tissue. So here's a picture of some breast tissue, and we've got all of our layers in this picture. And I'm going to jump to the slide that's color coded here. And we can see then that all those layers do show up under ultrasound, starting with skin at the very top, followed by the superficial fascia, the premammary layer, the mammary layer, retromammary layer, including the deep superficial fascia, muscle, and then chest wall. Remember, we have those ribs in there. Sometimes those ribs are a little scary looking, especially if you're expecting, multiple centimeters worth of breast tissue, and then there's this big black thing hanging out in there. Look, we're only 2 centimeters in, 2 centimeters, not even a whole inch in, and we're already through all the breast tissue. So remember to take a global look at your picture, identify those structures, set your depth appropriately, and now we know as we're scanning through, we're only looking through this very superficial part, looking for any abnormality, any structure, architecture changes in this layer. There are some other structures that are visible within the breast parenchyma. We talked about the Cooper's ligaments. Remember, those are kind of the skeleton of the breast, helps it keep its shape and support the structures. And we typically see those first and probably best within the premammary layer. And that's because they show up rather echogenic. And then we have the, a little bit hypoechoic fat that surrounds them. So here's that Cooper's layer coming through here, that very echogenic line. And they're going to look like lines that run through, and they're going to make the breast tissue look very lobular. Some other structures that are seen within the ultrasound are lymph nodes. We had a radiologist that would call patients back. They'd have their diagnostic, or they'd have their screening mammogram, come back for a diagnostic because something looked kind of weird, and they still couldn't get rid of this kind of weird spot, so they would send us in. But he would always put it out there as, I can only see it in one view. It's probably a lymph node. And so you pretty much had to scan half a breast, because remember, we needed both views to be able to locate where it is clock position. So he'd only be like, I can only see it in the MLO view, scan the upper half of the breast. We're like, cool, I'm just going to go search for a lymph node. So they're a little bit tricky to see. This one is pretty obvious, but they can be a little bit trickier to see. If we find them, though, that usually answers the question, what is that kind of weird spot? It's super, gets everybody on the same page, alleviates any concerns if there's something more concerning in the area. But this is a lymph node. We'll talk about lymph nodes a little bit more this semester, but we've got kind of a hypoechoic, this one's actually rather dark, hypoechoic cortex, and then we have a very echogenic fatty hilum to the lymph node. So this is a very normal lymph node. If we were to put color on it, we'd see just a little bit of blood flow coming right through the middle. The size, shape, and characteristics of this make it a very normal lymph node. Then some other things that you'll see in the breast, especially as we get up to the nipple, are the ducts. The ducts get larger as they extend towards the nipple. Now, if you're seeing super dilated ducts without any real cause, especially in older women, we might be concerned that there might be a blockage somewhere. So if we do see those ducts, we want to make sure that we follow them. Remember, when we're in the radial plane, we are long to the ducts. So we want to do a good sweep in the radial plane so we can elongate those ducts and really evaluate if there's anything within them. So let's talk about what those layers look like by ultrasound. The skin line is usually very bright and reflective. It's very thin. Remember, if you have something sitting in that very superficial area within the skin line, you can use a standoff pad or a giant pile of gel to give you some elevation off the skin, so now you can kind of evaluate that skin line a little bit better. There's something called a sebaceous cyst. It's a skin cyst or like a clogged sweat duct. And if you use that standoff pad, you can see that it's only within the skin. It's a great tool when you're using or when you're looking at very, very superficial structures. The subcutaneous layer then is also known as the pre-mammary layer. Remember, that has all the fat in it, and it varies from person to person as to how much fat is within the pre-mammary layer. But fat on breast ultrasound tends to appear a little bit more hypoechoic. When we look at fat in the abdomen, or we see fat in the leg, or fat anywhere else, it typically takes on a little bit more of a hyperechoic appearance. In the breast, it's more hypoechoic, especially compared to the skin and the glandular layer. Speaking of the glandular layer, we're down to the mammary or glandular layer. That usually is going to have kind of a homogeneous look to it, and it's going to have medium to low level echoes. Now, we had already mentioned in a previous chapter about fibrocystic condition, and this is where we're going to see a little bit more heterogeneity in that mammary layer. We're going to see lots of cysts and bright fibrous tissues running through it. So in your normal non-fibrocystic breast with maybe a little bit older patient, we're going to have a very homogeneous appearing mammary layer. Behind it then is the retromammary layer. It is similar to the subcutaneous layer, as it also contains fat, so it tends to be a little bit darker. It'll also have that bright superficial fascia running through it. Behind that then is the pectoralis major muscle. These are typically more hypoechoic, and muscles have striations through them, so that'll be a helpful tool to differentiate between the glandular layer and the muscle. And then, as we had mentioned with the Cooper's ligaments, you'll see those Cooper ligaments running through. You can see one here. They're going to be bright white lines, and they kind of make, especially that pre-mammary layer, they make it look like it's kind of balls of fat within the tissue. Here's another view of a breast showing the panoramic view of the breast. There is a tool on newer machines where you basically just slide the transducer in a line, and it'll just keep grabbing pictures, and then it kind of puts them all together. I'm sure you have panoramic view on your phone. You know, if you stand there, you take a picture, and then you slightly move a little bit, move a little bit, move a little bit, and you keep going in this line, and the phone or the computer in the phone recognizes where spots overlap, and then it makes this nice huge picture. It's really neat, right? So we can do the same thing with ultrasound. It's an awesome tool to really get a global view of an area that you're scanning when you can't fit it all underneath your transducer. So here's that panoramic view. They started at the chest wall, slid down and around the breast to the underside. This is the nipple area here. I know that because that pre-mammary layer does not sit behind the nipple. So here's that pre-mammary layer, and it kind of gaps, and then we have that next pre-mammary layer. We also can see our glandular or mammary layer in that central area as well. So that would make sense. Do that, all of this area is kind of converging up to the nipple area here. So if we look at this picture, again, we have the skin, pre-mammary layer, mammary, muscle here with those striations, and then we're down to the chest wall. And here it is color coded. Now, why do we do breast ultrasound? Probably the biggest reasons that we are going to do it are, first off, for palpable mass. Patient did their yearly exam at home, or they came in to their yearly exam at the GYN office and had the breast palpated for masses, and they found one. Or it's to follow up a screening mammogram that turned diagnostic. Those are probably the most common reasons that I've done breast ultrasound. Other common other reasons that you'll see, patient possibly suffers from mastitis. We've got a breastfeeding mother. Breasts are painful, has this bright red area on it. We need to take a look to see if an abscess has formed. We might also do it to evaluate for breast implants. Older breast implants had a potential to rupture. So we would check to see that the breast implant material is secured within the implant versus leaking out into the biological tissue. And then we also provide guidance for procedures, so doing breast biopsies or placing wire location devices for surgery. When you're getting ready to scan a breast, you want to make sure that you get a good patient history. Before every patient has a mammogram, they fill out a pretty extensive history form. They talk about, do they have any nipple discharge? Do they have any palpable lumps? When their last period was? Who else has had breast cancer in their family? What other cancers run in the family? It's a pretty exhaustive list. So if you have access to that, that is super. You'll get all the information that you need from that. But if you don't have access to it, or they're coming to you first because it's a young patient with a palpable lump, then just make sure to get a good thorough history, knowing what their risk factors are for possibly presenting with breast cancer. You also want to make sure that you are explaining the exam well to the patient. The minute a woman hears, we saw something on your mammogram, we need you to come back in, immediately is going to go to, I have breast cancer, immediately. If a woman feels a lump in her breast, she's immediately going to go, I have breast cancer. And so they're coming in, they're very nervous. They're very worried that they're going to get that diagnosis that day that they have cancer. And so we need to explain to them, give them the education, knowing that most lumps, most mammogram findings are benign, and really helping them through that time just to understand the process to help alleviate some of those fears. You also then want to make sure that you are also palpating any masses that they are feeling, making sure that you are feeling the same thing they are. I had a patient that had a palpable mass, and that's the reason she was coming in. When I got her on the table, she felt she couldn't find it. And so she was feeling all over, and then she's like, okay, no, here it is. And she's like, oh, but it kind of feels like it's up here. And it ended up being this whole line of just kind of like a fibrous band, a like really prominent Cooper's ligament. And it just kind of moved around with her positioning, and it really just felt like it extended through the whole breast. So that really helped us to kind of move away from, are we looking for a very particular pinpointed spot, or, can we hedge our bets on this? This probably isn't cancer because now we've found this Cooper ligament that corresponds with what you're feeling. So make sure that you are palpating the mass, feeling the mass that they're feeling, so you can have a better idea what you're scanning, and then can relate that back to the radiologist. If you're following up a mammogram, then you definitely want to review the mammogram. You will learn how to read mammograms, but as I mentioned in that video, you are not usually going to have to read a mammogram and then go scan a patient. Typically you have a radiologist on site, or you have a radiologist available by phone that will review the mammogram with you, tell you where to scan, and confirm the location. When you are selecting a transducer for your exam, you want to use a linear transducer, and you want to use the highest frequency that you have. The standard on most systems are going to be about a 12 megahertz transducer. There are some systems that have up to 17 megahertz, and then you might also want to have like a 9 megahertz transducer, especially for larger breasts. When you have the patient positioned on the table, you're going to start with them supine, laying on their back, and you will want them to then lift the same arm that you are scanning on, so the ipsilateral arm. So if you're scanning the right breast, raise the right arm. And then the next thing that you want to do is slightly roll them onto their contralateral side. So we have in our patient here laying on their back, arms up, and you can see her breasts are a little bit larger. Most of that tissue is falling off to the side, falling off laterally, where we have very thin tissue medially. If we roll that patient up just a little bit, we then move the nipple more centrally to the breast, and it flattens everything out. So as we scan through, we have an even scanning plane, even thickness, all the way through the breast tissue. It's going to make the lateral portion of the breast much easier to access as well. And then we know if everybody kind of rolls their patients into this flattened position, that we can easily find lesions that we might come across. We can find them again next time the patient comes in for maybe their biopsy or their wire loc. You also want to make sure to have a wedge on hand, so you can stick that underneath their side just to help support them, so they don't have to hold that position with their muscles. They can just relax back into the wedge. Now, with this patient, I do not uncover both breasts at any point. If I'm only working on one breast, there's no reason for the other breast to be out. Again, we're kind of going back to patient comfort at this point. They're already feeling vulnerable, and now their breasts are exposed, which is a sensitive area for a lot of women. So I typically have them only remove the one side that I'm working on. I keep the other side covered, and the minute that I am done with scanning, I cover them back up with a washcloth, step out of the room, let them get cleaned up on their own, so they feel like they have some privacy. Now, there's a couple different reasons that we talked about that we might be doing an ultrasound. One of them that we didn't mention, though, was to do a screening breast ultrasound. Screening breast ultrasound is intended to replace the screening mammogram, and it is not the preferred method for evaluating the breast, especially for the first time. The problem with that is that let me step that back. Okay, so breast work is very highly regulated, and the QA process that the mammogram techs go through, the records that they have to keep, if they do a mammogram, they have to send a letter out in so many days stating to the patient what the results were. If a finding is seen on that mammogram, now they have to call the patient back, and then they have to rate that lesion, and then the patient has to get a letter with the rating of that lesion. There are lots of regulations that go behind it. So when we are ultrasounding the breast, anytime we see something within the breast tissue, we have to document it, because now it has to make it into that documentation letter and be correlated with mammogram. So when we do screening breast ultrasound, it is up to you as the sonographer to sweep the entire breast looking for any abnormalities. And as you get a chance to practice some breasts or watch some more breast videos, you'll see that there are little shadows and inconsistencies that are going to catch your eye all over the place. It is very difficult to pinpoint, especially a very, very tiny starting cancer. So screening breast ultrasound is not the best method, almost solely because it's so user dependent, and that puts a lot of pressure on you and the radiologist. What is preferred is to have a screening mammogram, and then followed by a diagnostic mammogram and ultrasound. Now, the only time that we might start with ultrasound is in younger patients who have palpable lumps that wouldn't quite be of age to start receiving mammograms. So I believe it's around 30 and over will usually get a mammogram if they have a palpable pathology. So if a person has a palpable mass, then you want to again make sure that you are talking to the patient, asking them questions. How big does it feel? Where is it? Can you point it out? If they can only feel the mass when they're sitting up, then sit them up. Scan them sitting up. If they can only feel it in a certain position, get them in that position so you can feel that mass and scan that area. You also then want to feel the mass to see how big it is for yourself, to palpate it, to visually locate it, so when you put your transducer down, you can know exactly where you need to go. Quite often I will have the patient put one finger on the mass, I center my probe on their finger, and then I ask them to remove it, and with any luck, and usually it is, the mass is right underneath my probe, centered on my probe. If they can feel the mass, make sure to label those palpable masses, and then you also want to sweep the quadrant or sweep a couple clock faces either direction. Just make sure that we are covering that area. But don't go too far away from that palpable mass, because like I said, if you find anything else, you have to document it. Say you find a cyst 3 clock spaces one direction, now we don't know, was the palpable mass that cyst, or is it in the area that we didn't see anything? It gets a little confusing. So try to stick to the area that you're in. Following up to a diagnostic mammogram then is another very common reason that we will be doing ultrasounds. So again, make sure to consult with the radiologist to identify the area of interest that we want to scan. Scan just that area, again, for the same reason. We don't want to go out too far. If we start finding more things, then we have to document, possibly biopsy more areas or FNA more areas, and it just kind of creates a mess, more confusion for everybody, more work for everybody. So scan the area that is indicated and maybe a couple clock faces in either direction. Now when we label our breast ultrasounds, we have to make sure that our images are labeled well. We are kind of creating a roadmap for whoever comes after us. So a lot of times the patient is in our office, they have that diagnostic mammogram, they come to us, we scan, we might find something that we want to biopsy. More often than not, you're already booked for the morning. You've got diagnostic mammograms all day, and you don't have time to fit in a biopsy. They're extensive in time and resources, and most places don't have same-day appointments for them, but they will fit them in the next day or two. So that patient's going to be out and about, coming back, positioning has to be accurate again, and we need a good roadmap to find that lesion again. When I was first scanning ultrasound, we did a lot of breast work, and I found a lesion right where we were looking and got everything set up for the breast biopsy, and then we went to go in, and I had moved a little bit more out to the axilla, and we actually found a second breast lesion out in the axilla. So then we were kind of like, well, which one were we supposed to do? Because they were kind of in between the measurements, the centimeters from nipple. So it was a little bit difficult to follow which one we were supposed to do. And then, of course, that made more work because we ended up having to biopsy both places. And unfortunately, that patient did end up having cancer. But the axilla area was actually the more worrisome looking spot. The first spot that we were going to biopsy kind of looked benign, but the axilla looked definitely cancerous. So having a good roadmap for your peers, for your coworkers to get back to the correct spot is very important. So very first thing that we need to do, getting off my soapbox, first thing we need to do, label right or left breast. Just that's whatever breast you're working on, get that on there. You don't want to set it up for the wrong breast. And then we can talk about quadrant labeling. So quadrant labeling is a very generalized area. And when we talk about quadrants, we split the breast into 4 areas. And notice that the right breast mirrors the left breast, or upper outer quadrants are indicative to each breast. So upper outer, upper outer. Then we have our lower outer, lower inner, and upper inner. Again, they're mirroring one another. They are specific to the breast. Zone labeling is another tool that you can use. It is not used very commonly these days, typically because we can look at ultrasound, we can look at the mammogram, and we can kind of figure this out without having to label it. But the way zone labeling works is, first off, you pick a number, 1, 2, 3, depending on the proximity to the nipple. So if it's in the first third of the breast near the nipple, that's zone 1. The outer third then is zone 3. And then we look at the breast depth. So if it is very superficial towards the nipple, we're in zone A. If it is very deep to the chest wall, then we are looking at zone C. So you might label a breast, right breast, zone 2B. And then we know it's mid breast, mid depth. So it's just a way of kind of telling the eye where to look for that lesion. What's more common these days is clock labeling. So clock labeling uses the face of a clock kind of superimposed onto the breast tissue, and we label lesions based on their clock position. So unlike the quadrant labeling where they mirrored one another, clock labeling just moves from the right breast, the clock moves directly over onto the left breast. There's no mirroring. So it takes on the clock face directly as we would expect for each breast. So noon is noon. 1 is upper outer quadrant on the left, but 1 is upper inner quadrant on the right. So keep that in mind, that they don't flip-flop, they don't mirror one another. So in that case, then medial can be 9 o'clock or 3 o'clock, or lateral will be 9 o'clock or 3 o'clock as well. It all depends again on what breast we are imaging, so that's why we want to make sure that we get that breast labeling down first. As we move through the breast, we are actually going to kind of follow these clock lines out. When we follow the clock lines out, we're scanning in a radial plane. Radial kind of means the radius of the circle. So we're following around those wagon wheels to image the entire breast. When we turn 90 degrees to any one of these lines, then we are anti-radial. And we'll talk a little bit more about that in a second. But I like that this kind of shows us how we're also going to scan the radial planes at each clock position. The last thing that we want to put in our label then is the distance from the nipple. So you are usually going to have a ruler at your station. You're going to pick up that ruler, you put the end of it on the nipple, and then you measure to where the lesion is found. What I like to do is center my lesion on my probe, so I know that I'm measuring to the middle of my probe when I put the ruler down. So center it on your image, you should be centered on your probe, and then you physically measure how many centimeters from the nipple you are. You're then going to put that into the labeling. And so this is an entire label here. We have the left breast at the 2 o'clock, 11 centimeters from the nipple. As I had mentioned before, we do typically scan breast in the radial and anti-radial planes. This is true for really only breast imaging. So anti-radial and radial position depend on the clock position that you're at. So let's look at this one here. So we are at noon in the radial plane. Anti-radial then would basically just be 90 degrees to it. What's confusing about this though is that it actually really lines up with longitudinal and transverse at this plane as well. But let's look at a mass that's at 8 o'clock. Sagittal and transverse, we're still following our true long, true transverse, but with breastwork we really should be following that clock line out and then turning 90 degrees to it. So you can see that we're now kind of more in an X orientation over that. This radial, anti-radial, this is the appropriate way to image breast. This is how we want to image our breast lesions. This is how we want to label them. This is standard. Now it's not to say that you can't go back in and label sagittal and transverse to a lesion. That's totally okay too. Just make sure that you are also, and first and foremost, doing this anti-radial and radial positioning. If you decide to image sagittal and transverse, then you'll want to label that on your image as well. Now you might choose to do sagittal and transverse imaging. Maybe it shows the characteristics of the breast lesion a little bit better. Maybe in the sagittal plane you can see the spiculations off the breast. So it's absolutely okay, show what you need to show, but make sure you're labeling correctly. And then if we look at our 3 o'clock mass, again, long and transverse, that's normal orientation that we're used to for the rest of the body. And that again kind of matches up with anti-radial and radial. But look at, radial is following the clock face, the arrow out to the 3, where anti-radial is 90 degrees to it. So I just want to show you here on a breast again. If we are at the noon, this is off to the side here. This is radial. I am following the noon. This is radial to 1 o'clock. This is radial to 2 o'clock. This is radial to 3 o'clock if we're on the left breast. Actually, if we're on either breast, it doesn't matter. These are our radial positionings. Okay, so I'm following these lines out. These are all radial. Anti-radial then is going to be 90 degrees to it. So if this is radial, this now is anti-radial. This is anti-radial. This is anti-radial. This is anti-radial. You need to be 90 degrees to your radial position. So you'll have some practice in your workbook looking at radial and anti-radial positioning and to better help understand how to hold the probe in those clock positions. So then our final full complete labeling that I expect on your images then will be left breast or right breast, a clock position, how many centimeters from the nipple, and then radial or anti-radial. And we're actually going to go one step further in our labeling, and we're going to add in the quadrant that you're in, and that's just because I want you to practice recognizing quadrants and clock position. There are some abbreviations that you'll see in labeling as you watch videos and study other breast imaging. And what you'll commonly see is radial and antiradial are abbreviated down to rad and arad. CMFN stands for centimeters from nipple, and then subareolar and retroareolar are both the same area. That's right behind the nipple. And then AX usually stands for axilla. So these are common abbreviations that you can use in your breast imaging, both on campus here and while scanning at clinic. There are also some tips and hints that we can use to improve or to change our image. So the first one here that I want to discuss is harmonics. So we know that harmonics helps clear out cysts. It helps kind of make everything look pretty in our picture, and that's awesome for most of our imaging, but it can actually be a little detrimental to scanning the breast. So here we have a lesion in the breast, and the left picture is using fundamental frequency, the right picture is using harmonics. Now harmonics cleared out the supposed cyst, and it makes us think that this is probably truly a cyst. But in fundamental, we can see that there's structures within it. So now, do we call this a true cyst, or is this something else? Is this maybe a galactocele? Maybe there's milk in there. Maybe it's the beginning of an abscess formation. Maybe that's some sort of blood in there, some sort of debris. So we want to make sure that we use harmonics to evaluate structures, and then we also want to make sure that we take harmonics off. We will then label our pictures with harmonics on, with harmonics off, just to better understand what we're looking at, how our physics playing into our picture. Take a look too at the labeling. They've got their right breast. They're at 1 o'clock. They're in the 3B, so that's in the outer mid-range of the breast, and they're in the radial plane. So that's another example of labeling. Again, this is a little bit outdated labeling. Compound imaging is another tool that is on your machine. Philips machines call it spatial compound technology. It's SCT, and then GE calls it X-res beam. But the whole idea of it, if you remember from physics, that when you use spatial compounding, it basically layers multiple pictures on top of one another, and it looks at those 3 pictures and it displays what's consistent within those pictures. So the whole idea behind compound imaging is that it kind of gets rid of artifacts that we're seeing in the picture. So it just clears up the picture, and we can tell this is compound imaging on. It just kind of clears up the picture, makes everything a little bit more homogeneous. Nothing really jumps out to us. But when we take that compound imaging off, look what happens. That shadowing becomes really prevalent. And if this area wasn't shadowing, we might not be nearly as concerned as we are with the shadow. Shadowing typically represents malignancy. So now we're much more concerned about this area. It has steep shadowing. We can tell that it has very angular, dark appearance to it. This is very likely a cancer. But we can only prove that once we took that compound imaging off. So quite often when I'm scanning breasts, I will sweep through using the compound imaging technology to sweep through, get a really good look through. If you find anything suspicious, you then want to make sure that you take that compound imaging off, take a look at it without it, see what it does to your image. And you can apply this to other structures in the body. We know that gallstones should shadow. We know that we should see shadowing behind renal stones. If you can't really see the shadowing, or it's just not as prominent, take your compound imaging off and see if you can really get that shadowing to pop out. Compression is another tool that you can use. When you're scanning the breast, you're going to be using a moderate amount of pressure to be in contact with the breast tissue. If you come across a lesion, try squishing it. Usually benign and cystic structures are going to be squishy, where malignant structures do not. So you can try squishing it. Of course, then you're going to label your picture with and without compression and seeing if there's any change to the shape or size of the lesion. Echopalpation means to hold the palpable area with one hand, and then you put the probe on the area that you're holding. It just helps to keep a rather mobile structure immobilized so you can image it well. Fremitus is a term that you may hear. Fremitus is having the patient hum while you scan. And the idea behind fremitus is that when you have a structure that is congruent or just made of the surrounding tissue, it's all going to act the same way. So fibroadenomas are basically breast tissue. Cysts are fluid within the breast tissue. Lipomas, basically breast tissue. So if you hum over one of these benign findings, it's all going to vibrate, all going to show kind of this vibration pattern with the power Doppler. However, cancer is very stiff. It acts differently from the tissue that surrounds it. And so if we hum and we still have that negative filling area where that lesion is, then we are more concerned for cancer. So kind of an interesting tool that you can use. So again, you put your power Doppler on, have the patient hum while you are imaging the area, and look for any filling defect over the lesion. I had mentioned this earlier when we were talking about the skin using a standoff pad. The skin is this very, very bright line here. It's very, very thin on this patient. If this patient had something within that lesion, then we would want to evaluate it being a little bit further away. So to get further away from the skin, we use standoff pads. Now standoff pads are usually just kind of this gel block that you place on the breast or really anywhere on the body that you want to be further away. And then you get your dead zone a little bit higher, making this much clearer, much more diagnostic at that skin level. Now they've chosen to use the standoff pad because we can see this lesion comes right up to the skin line. If we were probe on the skin, we'd be missing a lot of this upper border of this lesion. Quite often I just use a giant pile of gel, and I use this for anything palpable on the body. A lot of patients will come in with palpable lymph nodes or just a bump somewhere in the skin. I use a giant pile of gel and then I just kind of float in the gel when I'm imaging that so I can get a good view of the entire skin surface and the contour of it. Doppler then is going to also be a diagnostic tool that you'll want to use. When you set up your Doppler, make sure that you are setting it up to be sensitive to flow within normal breast tissue. So we should have some little arteries, we should see some little lymph nodes, we can see blood going through them. Set it up so you can pick up that sensitive flow. And then you're going to bring your color box onto the area that you're interested in. I like to open up my color box enough so I do catch one of those tiny little vascularities out of the lesion so I can show the radiologist everything's set up appropriately. I'm not showing the radiologist that there's no color in this because my gain is too low, or there is color in this because this is just speckle going through here. So you want to make sure that your color settings are appropriate for breast flow and then use that on the lesion. Typically, lesions that have vascular flow are going to have more chance of being malignant. So here we have a ductal hyperplasia. There's just flow kind of going around and into it, so that's a little bit more concerning. Where here we just have a normal artery in the breast that we're catching. There's clearly no lesion that it's going into. Some other things that we can do with ultrasound, as we mentioned at the top, was to guide procedures. So here we have a cyst aspiration. This is a cyst found within the breast tissue. A needle has been inserted. We can see the needle here. We use the ultrasound to guide the needle into the cyst, and then we pull the fluid out of the cyst. Larger cysts that might become painful, this is a common treatment for them. Once we pull that fluid out, if it looks concerning, if it's cloudy or milky or bloody, we might send that off to pathology. If it just is kind of this clear yellow straw colored fluid, it's just a normal cyst, gets thrown away, patient's happy, lump is gone. They can come back though once we aspirate. FNA is another tool that we can use to get some tissue from a suspected lesion. This is not the preferred method for breast lesions. We actually see FNAs quite often with lymph nodes and thyroid nodules, but not for breast. But FNA, the whole idea is that you stick a very tiny needle into the lesion, you kind of jiggle it around a little bit, try to break loose some of those cells. Those cells then are sent to pathology for evaluation. What is preferred is to do a core biopsy. Now, a core biopsy is a procedure in which a large needle, a large bore needle, is inserted into the breast. And when you insert into the breast, it has kind of this hollow core to it. And when the biopsy gun is fired, it kind of splits off this like little sharp tubular knife, and it grabs a hunk of the lesion and pulls it back into the chamber. And now we've got like these little wormy looking tissue samples that get sent off. These are much better at diagnosing lesions just because you get more tissue, you get a little bit of the surrounding tissue, so now you can differentiate between healthy and cancerous tissue a little bit better. Once we are done with the core biopsy, what typically gets put into the breast is called a marker. They're titanium. They stay in the breast for the patient's entire life, and they actually come in a bunch of different shapes. This one is my favorite. It's just the little breast symbol. And then that will show up on future mammograms showing that an area has been biopsied. Now, if this area ended up being cancer, the marker and the lump would have been removed, or the breast would have been removed, and then that whole area would be gone. But this area was biopsied, proven to be benign, and now there's just a little marker in there letting the radiologist know that this area has already been evaluated. And lastly, we do wire localization. So once a lesion has been identified and has been identified as malignant, and they're going to have a lumpectomy, they will come to the ultrasound suite the day of their surgery. We find the lump and we place a wire. So now the surgeon can just follow this wire down into the tissue, grab a couple centimeters around that tissue, completely, fully circumscribe that area, and then pull that tissue out. After the surgery then, that lump of tissue is sent back to mammogram, so it's just a lump of tissue in a tray, and they do a mammogram on it. And their goal then is to see that they did indeed get all the way around the lesion of concern. Now, we've talked a lot about mammography, and mammography and ultrasound really do go together. They support one another very well. And that's kind of the cool thing about ultrasound. It's a good thing to remember about all of your ultrasounds is that CT, MRI, X-ray are all there to help aid in our diagnosis. If we can't see it, another modality should be able to. So don't stress out if you can't see something, just be honest and do your best. But mammography and ultrasound go together well, especially for the breast. And with mammography, they do 2 projections of each breast. The MLO and CC views are the most common for a screening mammogram. So our MLO view takes the breast and almost moves it into a vertical position. So we can see we have our breast hanging in the natural position. The paddles then are compressed and they twist the breast up. So now the lateral side of the breast is higher than the medial side of the breast. The X-ray beam then comes through there, and what we get is a picture that shows us above and below the nipple. This bright white area here is the pectoralis muscle. So they go all the way back to the chest wall, making sure to see as much breast tissue as possible. This then is the nipple. The other view is the CC view, stands for craniocaudal view. And this is going to flatten the breast out in more of a horizontal plane. So now we have the breast plates on either side, X-ray comes from above, and now we can see lateral and medial to the nipple. So these 2 views you'll learn in How to Read a Mammogram help us to identify where a lesion is located. So that brings us to the end of our lecture. I think it's going to be important for you to remember all those tools that we have available to us as sonographers. Remember that there's other imaging modalities. Be aware of the procedures that we are involved in, and first and foremost important, know how to label your location on the breast, the difference between antiradial and radial, and then sagittal and transverse, and how to position a patient appropriately, what transducer to use, And then you also really need to be able to recognize the breast layer tissues by ultrasound.